So, Dr. BP Kashyap is the person who is standing here.
Good morning,
Dr.
everybody.
Vibhuti Bhushan.
Good morning, everybody. The presentation is not loaded, madam, and the same PPT was loaded on 4th, and they are unable to get the PPT. And this time, I tell you, the audiovisual team of Echo Global had been very, very poor. The first slide never moved in any hall. We have to keep on reminding that the slide is not moving, slide is not moving. And the very simple thing, this is already preloaded there, and it is not coming here. So I'm going to complain about this Echo Group. Aapka naam itna zyada hai, and everybody is paying you so much, and you are not able to perform your job. We will officially make a complaint against you. So friends, leave apart all these things. There are certain features. Number one, pseudo-exfoliation. There are a lot of problems are there. Number one is a non-dilating people. Number two.
No. I said that prerequisite in my case
Yeah.
was a 5.5 millimeter dilatation.
Yeah.
So let him finish.
Okay.
It's a non-dilating people. Number one, it's a progressive disease. Number three, the patient tends to get glaucoma after some time, and there are a lot of deposits in the lens, and the zonal ligaments are very, very weak. Now, the question is, if you are doing a phacoemulsification, you have chosen that, and you find that the patient has got toric astigmatism. It needs toric glasses. Now, you have to see to it that in pre-operative time, everything is fine. The pupil dilates to the extent that you'll be able to complete the operation, number one. And number two, you'll be able to put a lens inside. So then you can start with the operation, you can proceed with the operation. But the question is whether you will be able to put a toric lens or not, whether you should put a toric lens or not. I would say, why put a toric lens? The opponent says, if you can put a lens, why not a toric lens? Because there is a progressive weakness of zonules. It will further move. And it will further move, and then your toricity is gone. So what is the idea of putting a toric lens? Number one, there are two things. Number one is zonules, and number two, the bleb formation. Can you assure that the bleb will be good and to the optimum? No. Sometimes the bleb are very high, sometimes there is a flat, and sometimes the bleb do not even form. Then you have to do certain maneuver to make the bleb. So since the bleb is not constant all the time, whatever method you do, so the bleb may be bigger or smaller, and it will affect the overall diameter of the toricity of the cornea. So why put IOL, especially toric IOL? IOL, fine, because you have got all the prerequisites, because you have seen that the ligament is fine at that time, you can go ahead with the IOL. But why toricity? What will happen if there is a higher bleb? What happens if the lens gives way? What happens if you have to readjust the sutures for the trabeculectomy? So in my view, the putting a toric lens is putting the patient into danger. If you have done your SIA, it's fine. If the bleb is formed uniformly, it's fine, but it will never form. And then there is zonal weakness. So in that case, I would suggest that putting a toric IOL is not justified for the patient.